virtual conference on HIV in humanitarian settings, and give the first floor to Hillary, who is going to give you some background on the coming about of this conference. Hillary?
Thank you so much, Katrine. Hello, everyone. My name is Hillary Wardinger. I am the lead of the STIs and HIV sub-working group for the IWOG, the Interagency Working Group on Reproductive Health and Crises. IWOG, as many of you know, IWOG was started about 25 years ago in response to a growing need to elevate sexual and reproductive health in crises and in humanitarian settings. Since then, we have the IWOG as a consortium has conducted multiple, has been a lead for sexual and reproductive health around the world, elevating multiple issue areas and really bringing attention to sexual and reproductive health in these times of emergency. Usually we host an annual meeting. This year was to be held in Bangkok in 2021 or in 2020. Unfortunately, due to the COVID-19 pandemic, that was unable to occur. But we wanted to allow for our all of the wonderful research and implementation science that was to be presented. We wanted to give it the space and a venue for everyone to learn and grow from. So we started the streaming IWOG 2020 webinar series. This webinar series will span the next 2 months, and there will be topics covering a variety of different issue areas. And this one today on HIV, we're very excited to have you joining us for. We have some wonderful panelists with some amazing work, and we're really excited to have you. If you're interested in other webinars, I'll post a link in the chat, and you can also find more information on IWOG's website, which I will also post in the chat. So thank you all again for joining. We're really excited to have you. And
Hi.
Glad you could make it.
You want to know? I mean, 2 minutes at the same time, but.
Sorry, Hillary. Then I'll chip in. So together with the IWOG STI and HIV sub-working group, UNHCR organizes this panel. That's me and Megan and Anne, who unfortunately cannot join us. I would like to add to this that we should consider this panel at this particular moment in time particularly useful as a potential input into the reflection on HIV in humanitarian settings and a contribution to the larger discussion of the upcoming UNAIDS strategy. So the current UNAIDS strategy goes until 2021, and the process for a new strategy 2021 to 2026 is going to be happening through the second part of this year. And we hope that some of the reflections coming out of today's meeting can raise reflection about considerations that are specific to humanitarian settings and feed into that larger strategy discussion. So I hope that that is possible, and I'm sure it's possible because we have a lot of very knowledgeable people that have joined. There's a huge list, by the way. Megan has said there's over 100 people have RSVP'd. Let me quickly give you 1 minute on logistics. Megan has the complete control of us, so she's going to mute you if you are disturbing. There's a chat box, so if you have actual questions on the presentation, we would invite you to put them into the chat box, and then Tim, who's the moderator, is going to come back to your question, or you're going to get a written response. The overall idea is that you will get a presentation from each of the 4 panelists, about 15 minutes, and that we leave time for questions and discussions. And with no further ado, I shall be handing over to Tim and thank him very much for moderating this session.
Thank you very much, Katrine and Hillary. So welcome everyone. I'm Tim Sladden. I'm a sexual health advisor with UNFPA, the Population Fund, and it's a great pleasure for me to moderate this session today. We have apologies from Fatih Turkey of the World Food Programme, who was going to moderate but is unfortunately unable to be with us. So I'm delighted to step in for Fatih. So we've got lined up, I think, a very interesting session for you with 4 very varied HIV interventions in humanitarian settings. And so, as Katrine said, we'll run through the 4 presentations. Each presenter will have about 15 minutes. And you'll see the chat box down at the bottom. If you've got any immediate questions or comments, please just type them into the chat box and we will run through all the presentations. Then we'll come back to addressing as many of the issues that have been raised as we can in an open discussion at the end. So I think I'll start now. We have 4 panelists, the first of which we have Sandra Harless, who is a Senior Public Health Officer with UNHCR. And Sandra is a nurse with an MPH and a long experience in humanitarian work. Currently, she's the team lead for UNHCR's health and nutrition response at Cox's Bazar in Bangladesh, working with the Rohingya refugees in Cox's Bazar. She's worked previously in Ethiopia and Iraq, and also been a health advisor with the Malteser International Organization in Germany. So Sandra's going to address us with the health and protection needs of the Rohingya refugee women, men, and transgender persons involved in selling sex in Bangladesh. Thank you, Sandra.
Thank you, Tim, for the introduction, and good evening, colleagues from Bangladesh here. Thank you. And thank you for the opportunity to present today to you on addressing the health and protection needs of Rohingya refugee women, men, and transgender persons involved in selling sex. Next slide, please. During the presentation, we'll give a short overview on the situation in Bangladesh, followed by a needs assessment that we did in the initial phase before we started the project, and then on the interventions that we conducted before. At the moment, there are more than 860,000 refugees living in Cox's Bazar district, which is in the south of Bangladesh. Most of the refugees arrived after a massive influx in August 2017, but there are also refugees who came during earlier influxes, including some who have been here since the 90s and even before. More than 600,000 of the refugees live in a mega camp that is one of the largest camps worldwide, which is administratively divided into smaller camps, but we have about 600,000 refugees living in the same place. The camps are next to the host community villages and towns, and we have Bangladeshi host community members also living inside the camps. So traditionally, there have always been close ties and exchanges between the 2 communities. Next slide, please. The HIV prevalence in Bangladesh is very low, with less than 0.1%. The prevalence among female sex workers and MSM is similarly low, with just about 0.2% based on data from 2015. Now, with the arrival of the new refugees, a key concern from health authorities was that the higher HIV prevalence in Myanmar could contribute that the refugees could potentially spread HIV in the camps. The prevalence in Myanmar is less than 1%, but comparatively higher among female sex workers and MSM with 8 to 9%. For the Rohingya population, there is no HIV prevalence at the moment available, but findings from more than 6,000 HIV tests done during PMTCT in the first half of this year indicate a prevalence of 0.1% among those tested. Likewise, we're doing testing for all the refugees who are identified with TB and found that 0.6% were co-infected with HIV based on about 4,700 refugees being tested and a testing coverage of 96% in 2020. So the prevalence seems to be low, but we still lack concrete evidence. In the next slide, we will share findings of a needs assessment that was conducted in mid-2018. which aim to basically analyze the situation of the key populations and their specific needs. We used a mixed methodology approach, including a desk review, interviews with a large number of persons and focus group discussions, and also field visits to different facilities accessed by the community that we interviewed. And then we conducted a follow-up needs assessment end of last year to help us see how to further shape the programs. Next slide, please. The majority of the women that we interviewed were initially forced, coerced, or deceived into selling sex and worked mostly through a pimp. At the time of the first assessment, all of the women that we talked to were working independently. And when asked about why they started initially and continued, poverty and the lack of alternative livelihood opportunities were really mentioned as the key drivers. The Rohingya refugees are not allowed to work and required to live in camps, making it virtually impossible to have an independent livelihood. Most of the host community members worked from apartments or hotels, while most of the refugees at that time worked street-based, much more dangerous activity in the perception of people. All that were interviewed reported very high levels of harassment from clients and authorities, but also from families and communities. It's a very traditional society, a Muslim society here, with quite strict norms on marriage and sex outside of marriage. Most of the violence and abuse occurred around price negotiations and condom use. And all those that were interviewed at that time felt that there is no support mechanism available to them, including access to clinical management of rape services or justice. And this was linked in part certainly to fear of, for the refugees, or fear of authorities based on their previous experience in the past. And those that we interviewed mentioned that they never sought justice after episodes of violence. Next slide. At the time of the first assessment, the Rohingya women were only engaged in sex work outside of the camps due to the stigma and fear of being found out in their own community. And they also felt that they were further marginalized due to their refugee status, which would further then limit their access to services in their perception. For Koti and Hijira, they had often left the camps in the very, very early day after the influx because of the very high stigma that they faced. So they lived illegally in the host community and experienced really stigma and harassment throughout their life, including back in Myanmar before they arrived here. Next slide. A key part of the assessment was also to look at the available services for the population. What was reported from those interviewed was a strong reluctance to seek any services inside the camps for fear of being found out to be a sex worker, or that question would be asked, or especially if women were unmarried and would be approaching health staff with an STI around how could this be possible if you're not married, and where did you get this from? So in the very early phase of the response, facilities were also not well equipped to deal with STIs and the special needs of key populations. There was a lack of training, and also poor attitudes among staff were areas of concerns. Hijira and Koti felt uncomfortable to access any public services, also in the host community, due to stigmas faced. There were also some positive experience in the main district hospital in Cox's Bazar, and especially in the existing 3 drop-in centers, but overall service opportunities were too limited. There was also concern around gaps of HIV and gaps of knowledge in HIV and STI transmission, and inconsistent use of condoms. Next slide. There were also protection concerns for the Rohingyas focused around the violence experience that we discussed briefly in the earlier slides. Sex work is perceived as illegal. It is not illegal, but it's perceived as illegal, and authorities have been reported to harass those who report any incidences with customers if it's connected to sex work. So questions would revolve around, why did you go with this man, and what do you have to do with them, and it's your own fault. So very much a blame attitude was reported. And an additional protection concern was the lack of documents, including for the refugees registration cards, which would enable them to access additional services such as food distribution in the camps. So in the next slides, we will present you the 4 areas that have been implemented, that we have focused to implement in follow-up of the assessment. Next slide. So we started in October 2018 a comprehensive package of health and protection services that is offered outside of the camps. We established 3 additional drop-in centers for female sex workers, and those are supported by UNHCR and our partner Lighthouse. And the remaining presentation will focus on achievements and intervention in relation to the female sex worker program. In addition, a center was also opened for men and the transgender community by colleagues from UNFPA and Bandu to also provide more access to services there. So the centers are either located in Cox's Bazar town, which is a major tourist town, or are located next to the camps, the major hubs, where they are accessible to both populations. The drop-in centers offer a wide range of services, including health treatment, HIV testing, mental health and psychosocial support, and also simply areas to chill out and take a rest from the day. From the centers, we have incentivized peer educators who conduct visits to the areas where the female sex workers are working, including the streets and beach areas. There were specific training packages developed building up on the experience elsewhere in the country, for example, on STI and HIV prevention and condom negotiations. And sex workers were provided regularly with condoms and lubricants. One of the feedbacks in the early phase of the intervention was that the street-based sex workers had no place to go at night if they had no clients, and as a result they slept in parks and have experienced rape and violence as well as theft of belongings and money. So one of the core requests when we had the first follow-ups to the project was to set up a safe house for GBV survivors and sex workers in need of accommodation. So we had for this year only 69 clients because we needed to make some adjustments due to the COVID situation in the terms of space. From the host community, we reached more than 1,000 women and girls so far, and an area of great concern is the large percentage of adolescents among those that we are reached. In the next slide, the interventions in the camps started only in the first half of 2019, following continuous discussions with the target groups that revealed that selling sex in the camps has become much more common. So we started a pilot in 7 camps, very, very careful, with a very, very low visibility, and expanded them to 15 camps by now, using a very similar approach to outreach. And also, again, the similar training packages adjusted in the languages and commodity provisions. Then we also established linkages to the drop-in centers, and by now we reached much more than we expected. We reached 1,670 sex workers, female sex workers in the camps, refugee sex workers, and with a similarly highly concerning number of adolescents being engaged in sex work. In 2020, we conducted so far nearly 1,000 HIV tests for refugees and Bangladeshis. We had only 2 women identified as HIV positive who were referred to government services and started on ARTs there. Next slide. So the third area of intervention was to strengthen referral linkages between the new drop-in centers that were set up and existing health and protection services in the host community. So for example, if someone needed a screening for cervical cancer or legal service for protection, we have established referral partners that we are using. In the camps, it was much more difficult. We identified a few trusted health facilities where we trained the health providers on the special needs of female sex workers. And this has resulted in the feedback in a much easier access to healthcare in the camps. One of our facilities reported just last week to us that in the first half of the year, more than 900 consultations were conducted there for female sex workers for a variety of different issues. So it is a field where we have made much progress, and we similarly plan to train protection service providers in the camps, but made less progress there due to the current restrictions in services in the camps in COVID-19. Next slide. The last intervention area was to strengthen the capacity and coordination among partners. We had interagency planning and monitoring missions before the COVID crisis started under the leadership of the National AIDS and STD program, which is very involved and gives really very good and very dedicated guidance to the programs. We followed up then from there with revising the existing HIV framework for Cox's Bazar together with all the health sector partners to allow for expanded service provision. And then we have, of course, regular trainings from different units, protection, health, and other partners, and exchange visits among the partners to foster learning between the different facilities. And the overall coordination has been integrated in the health sector coordination to avoid setting up a parallel mechanism. So in our next slide, we have a look at the main challenges and opportunities. Among the main challenges is certainly at the moment the current COVID situations. Sex workers' livelihoods were severely impacted due to movements restrictions. A lot of the income came from Cox's Bazar as a tourist town. Tourism has stopped, but likewise in the camps there are less opportunities to earn money, so hence also less opportunities to spend money on sex work. And likewise, also the program the program focus shifted due to COVID, with competing priorities, but also with public health restrictions, which allowed us, for example, not to conduct trainings for the past few months. Maintaining confidentiality in the camps during peer educator visits, for example, is extremely challenging. The camps are highly densely populated with neighbors living door on door, just separated by plastic sheets. And the protection support requires really further strengthening, and we feel a special focus needs to be on supporting adolescents there. On the opportunities, we had a very positive acceptance on the activities in the camps. We were initially worried that nobody would come forward to discuss with us. So we have gradually expanded and will expand this further to other camps as well. And another area that we want to explore further is linkages to alternate livelihoods programs for those women who request support in this regard. So in conclusion, on my last slide, it's possible to implement essential services for women, men, and transgender communities selling sex in a humanitarian context, even in such a highly constrained and conservative environment. More attention is needed to the linkages with protection, with special emphasis to support for adolescents. And what we also really felt is that the comprehensive needs assessment in the early phase of the response really greatly facilitated the design of the interventions and to help to establish the linkages between sex workers, communities, and different service providers. Thank you very much.
Thank you very much, Sandra. That's an amazing intervention with a very vulnerable group, people selling sex in humanitarian contexts, often for the first time, and with a steep learning curve on condom negotiation and many challenges, but a very nice rounded program that you have there. We will keep the questions till the end, but please do either raise your hand at the end or type in any question or comment for Sandra in the chat box. Thank you very much. So now we'll move to Tessa Ann van Bokholt, who is a reproductive health officer with UNHCR. Tessa is a medical doctor from the Netherlands. She has a Master of Global Health, and she's just recently joined UNHCR's Regional Bureau for the Eastern Horn of Africa and the Great Lakes in Nairobi. And previously she's been with Uganda, UNHCR. Tessa is going to talk about outcomes of a prevention of mother-to-child transmission program in a post-emergency setting, a refugee context in northern Uganda. Tessa, you have the floor.
Thank you, Tim, and thank you, IWEC team, for this opportunity to present today for this crew. I would like to appreciate also Jeddah, the nurse we saw on the first page, who really contributed towards the program as well and has a lot of initiatives into this program. Here you see him together with a family support group to provide care to the people living with HIV in the north side of Uganda. Next, please, Megan. So to draw a little bit of a context in this setting, Uganda in general, so the national program has achieved great successes since 2009. So the national program, the coverage increased from 27% to over 95%. And this has resulted in a decrease of mother-to-child transmission rate from 29% initially in 2009 to 3%. So for the north side of Uganda, there was a big influx of refugees in 2017 and 2018 due to the crisis in South Sudan. And currently it hosts around 800,000 refugees, so mainly South Sudanese refugees, and they reside in 6 different settlements throughout the north side of Uganda. So during this influx, some new settlements were also established. So we look at a new situation, and some older settlements receive new refugees. So as we know, Uganda is known for its liberal refugee policy with freedom of movement and the right to live in settlements rather than camps, which means refugees are not confined to a certain area, but they can move freely across the country, either to visit other family members or to gain some income. But we also figured this could be a potential risk for the follow-up of HIV clients with increased movement in this kind of setting. Next, Megan. Thank you. So during the emergency, the program was focused on establishment of health clinics. As it is a rural area, there were only a few government facilities already present at the time, but not enough to cater for the new population that was being hosted in this area. So there was a focus on temporary clinics and outreaches also to provide care to the community that was settling into this area. Also, the integration into the national system was a priority from day one, as government facilities were initially the only ones accredited to provide HIV care and ART treatment. So in the beginning, the refugees were limited possibility to get access to HIV care. However, with partners, we arranged transport to get them to the facilities where they could get their care that they needed. And as UNHCR and also other partners in the region, we had early advocacy for accreditation of the refugee facilities that were established. And in 2019, which was 1.5 to 2 years after the initial emergency, most facilities were accredited to provide PMTCT programming and HIV care. And in addition, the health partners also established a network with the other settlements to follow up clients that would move across different settlements. Later, after the initial emergency, so 1 year more or less after the emergency, a program was also started with family support groups, where they established groups to support mothers and pregnant women in the prevention to mother-to-child transmission program, where they were supported with counseling and to facilitate peer support among them. Thank you, Megan. So for this study, we wanted to see what are the outcomes of an integrated PMTCT program among refugees in a post-emergency setting. So to see if we improved over time, to understand the strengths and the weaknesses of the PMTCT program in the settlements level, and to provide insights into future programming during an emergency, post-emergency in a refugee settlement setting rather than in a camp setting. So if we look at the methods we used during this program, so there was a challenge, as normally with PMTCT studies, you would compare different cohorts with each other, where each baby born in a certain year would be compared to the babies born in the other year to look at the outcomes. However, due to the short nature of the settlements, we could not have long-term follow-up of this. And this is why we chose a little bit of a different approach, where we collected data from the ART registers, the Early Infant Exposure Register, and the client cards. And we also chose some different outcome measures where we already looked at the first PCR moment, which is after 4 to 6 weeks of the newborn, the second PCR, which is 9 to 13 months, and the last one would be the antibody test at 18 months. But we accepted that we would not have the results of every cohort into this study. So we included 2 settlements that were both newly established during the emergency, which would be Palarinya and Mvepi, that both currently host over 200,000 refugees, but at the time around 170,000. And why we chose these 2 settlements was because they were both completely new and experienced kind of similar challenges with government facilities that were only initially accredited to provide HIV care. In collaboration with the HIV counselors and the reproductive health officers of partners, we also did some interviews with the women that attended the PMTCT services. And we also interviewed the HIV counselors themselves to see what they found of the strengths and weaknesses of the current program. And the data were collected between July 2019 and October 2019. So if we look at the initial result, we were able to include 77 mother-baby pairs. So 21 in the cohort of 2017, 37 in the cohort of 2018. And for 2019, we only included those babies born between January and April, since they were the ones that already had an outcome of the first PCR result of 4 to 6 weeks. Out of these 77, only 1 baby tested positive at one point in time, which would make a positivity rate of 1.3%. But I'll come back to this later, as I think we need to look at this in perspective. All babies were exclusive breastfed, which we thought would be most likely due to the success of the nutrition programs where pregnant and lactating mothers are supported with their nutrition throughout the entire period. And also health education is being enforced during these times. If we look at the second page of the results, we looked at the time of inclusion of the mothers into the program. And as you can see, throughout cohort 2017, only 1/3 of the women was identified during breastfeeding. And this reduced to 16% in 2018 and 14% in 2019. And we can also see an increase of the identification of the mothers before pregnancy, which would mean we had more chance to control the viral load, better follow up, and in the end, hopefully a lower chance of transmission to the child. So this is one of the things we saw throughout the program. If we go at another outcome we looked at was the exposure, the implementation of nifurapine. So according to the protocols, nifurapine is supposed to be started within 72 hours after birth. As you can see in 2017, 63% was started within the 72 hours, and 32% was still, 16% was not started, even though according to the guidelines they could have started. And then you see the last bar, which is when the mother was only identified during breastfeeding, and therefore the child could not start within the 72 hours. So you see that the follow-up of the protocol increased throughout cohort 2018 and 19, where we at least had no babies that were already identified during the pregnancy or before, but did not start. This did not happen anymore during the consecutive 2 years. If we look at the completion of the nifurapine treatment, this was either 6 or 12 weeks, depending on the criteria which the infant met. We can also see a seeming improvement of 63% that completed in 2017, compared to 86 and 90% in 2018 and 2019 cohort. However, we do have to note that there was some documentation gaps initially during 2017, so there might have been more that completed, but we cannot be sure because of the data. If we look at the last one, here you can see that also the results displayed per cohort. And as you can see, the positive baby was identified during the first PCR in the cohort of 2019. You can see on the right side. But I think it's more interesting to look at the last 2 follow-up. As you can see, during the first PCR, this was 11% in the cohort of 2017, 0% of the cohort 2018, and 5% in the cohort of 2019. But you can see that the loss to follow-up increased over time. So when we look at the second PCR, it's already 37% in the first cohort. And we end up with 1 out of 4 babies being lost to follow-up at the time of the antibody tests. which means we don't know the results of this baby, and we don't know if this baby is still in care, which is quite a big percentage. If you look at the 2018 cohort, you can see that the loss to follow-up decreased from the second PCR moment. So there was 37% of the first cohort, but only 8% in the last cohort. As you might notice, is that it doesn't make 100% of the second PCR in cohort 2018. That was because at the time of the study, some results were still pending of the PCR. But all those babies that were not included, we don't know the results, but we do know they were still in care during this time. So we can say that the loss to follow-up reduced over this time. Another important fact to note is the transfer out, which means that the facility where we were looking into the data doesn't have any follow-up data of the baby anymore, but they do know that they transferred the file to another facility. And here you can see this was also quite a big proportion over time, with 5% initially in 2017 at the first PCR, up to even 3 cases in the end. So if we look at the positivity rate, we can actually say that during the antibody testing of the 2017 cohort, over 40% of the babies, we don't know the results of their last moments. So actually the positivity rate we found would definitely be on the low side, as we don't know a lot of the results of the babies yet. Thank you, Megan. So if we look at the interviews we had with the key informants, we saw, and those were the mothers that were joining into the family support groups. They mentioned there was a lot of stigma in the community that prevented women to seek help from the facility or having them to attend to facilities far away from their own community, meaning they had to commute long distances to get to the facility and get the care they need. And stigma could even lead to relocation, where they would move to another settlement or another community because they did not want to be identified in their community as living with HIV. And also sometimes they mentioned that it would not just because of stigma, but also because of family reunification. As family members did not cross the borders at the same time during the emergency, sometimes they would reunify themselves with other family members in a different settlement. So we looked at what the HIV counselors thought were the strengths of the programs. They all mentioned that was integrated outreach was really one of the strengths, where HIV testing was also provided, and antenatal care services in the community, which would allow women to be earlier identified. On top of that, the pregnancy mapping that was supported by UNFPA throughout the program that encouraged facility deliveries and therefore helped us to start early on the routine for those women that were identified positive. And the network of village health teams, which can be seen as community health workers, helped us to lower the numbers of loss to follow-up, since missed appointments could be followed up in the community and brought back to care. And lastly, the family support groups were also mentioned, especially when they were still providing transport refunds as a way to overcome transport barriers, but also to get peer support and counseling from fellow women that lived with HIV and to see how they could overcome this. So if we look at the key findings summarized, we can say that the positivity rate found in this population with 1.3% seems within the 3% benchmark of Uganda. But it's important to note that both the cohort of 2018 and 19, the second PCR and antibody tests were not all collected. And also that we don't know the results of those lost to follow-up and the transfers out, which made quite a big proportion. And I think similarly, it's a fairly small study group to draw this wide conclusion. So it's with a lot of benchmarks that we have to make this statement. However, the early identification and initiation of HIV women seem to improve over the 3 years post-emergency. Better monitoring, guidance, and counseling before and during the pregnancy can reduce the chance of HIV transmission from mother to child, as viral loads are better controlled and pregnancies can be planned. The early initiation of NVP and the completion of the treatment also seem to improve over the year, which can also help reduce the risk of the HIV transmission from mother to child and improve the quality of the program. The loss to follow-up reduced from the second PCR and the first and second PCR over time if you compare the cohorts to each other. However, still 1 out of 4 babies was lost to follow-up in the cohort of 2017. And I think also notably that there was a relative high number of transferred out, which could be a sign of the mobility among the refugees, as was also mentioned during the interviews that the women self-relocate or do family reunification for reasons of stigma. it's important that the care is continued for these women so they don't become lost to follow up in the end. So the challenges we experienced throughout this is that there's a challenge to collect individual data in this setting, especially during the emergency setting, as initially women were only going to government facilities and later other facilities were also accredited. So they were transferred out, but this limited our possibility to follow up individual cases. The initial lack of integrated services made it difficult to plan for PMTCT. However, the initial focus for these services improved the inclusion of the women in an early stage. And the loss to follow-up remains one of the biggest challenges in this setting, especially long-term follow-up and follow-up in the initial emergency phase, as we mentioned for the reasons before, and also cross-border movement back to South Sudan is a common issue we witness in the north side of Uganda, where we lose clients to follow-up. The way forward and lessons learned is that it's good to have an early advocacy for inclusion of refugee healthcare services into the national system, to ensure that accredited services are now in closer proximity of the mothers and enable easy access to the PMTCT program to reduce transport barriers also for these women. The community-based interventions such as pregnancy mapping, the integrated outreaches and community dialogues and HIV testing at community level, and even a network of village health teams can help in early identification of pregnant women and people living with HIV. And this will give the opportunity for monitoring and counseling and therefore better follow-up during the pregnant and lactating period of the mother. And there needs to be a focus on keeping the mothers in the program, linkage to other settlements and address the stigma, because with this loss to follow-up, especially within the first cohort that was included during the emergency, it's important to see that we have linkages to the other partners and facilities in the other settlements, so these mothers can be included at a different level or in a different settlement and are not lost to follow up. And this deserves attention into a PMTCT program from the beginning onwards. So I want to thank everybody that helped collecting these data, which include Medical Teams International and UNHCR at the different levels of their organization. Thank you so much.
Thank you very much, Tessa, for another very interesting, great program with real attention to the detail needed in a protracted refugee setting. It's so essential to keep these PMTCT programs going, and as you've mentioned, it's very challenging with very mobile population and some loss to follow-up, but a very detailed presentation. Thank you. Now we'll go to our third presentation from Miata Johnson. Miata is a public health officer, again with UNHCR. She has a Bachelor of Nursing degree and an MPH, majoring in epidemiology, and is currently working in Tanzania as a public health officer, providing leadership, technical support, monitoring and evaluation to UNHCR's public health program, and to ensure that refugees continue to receive access to care. Miata has a very long public health career and has worked previously on PMTCT in Liberia, and also has been a consultant with UNAIDS and the World Food Programme. So Miata is going to talk about HIV partner testing in a refugee emergency setting, and this is a case study from Nyarugusu refugee camp in the Republic of Tanzania. Miata, please proceed.
Thank you, and hello to everyone. So the structure of my presentation will be a quick background of the refugee situation in Tanzania, and I will also give a profile of Nyarugusu refugee camp and an overview of the health program, followed by the interventions and results of the presentation I'm doing. So quickly, in Tanzania, we have over 280,000 persons of concern, and these are mainly refugees and asylum seekers. For camp-based population, we have around 241. And if you look at the presentation, you will see Nyarugusu camp is the largest camp with the population of over 136,000. We have 2 other camps, namely Nduta and Tendeli camp. And then we have some refugees that are situated within villages in Kigoma region, and also a small case law in the urban setting. Next slide, please. In Nyarugusu camp, this is like details of the demography of the population we have there. So basically, the camp was established in 1996, and up till 2015, it mainly hosted refugees from the Democratic Republic of Congo. And then from 2015, we had the Burundian emergency where we had refugees and asylum seekers coming into Tanzania, and were also situated in Nyarugusu camp. 48% of the population is male, and then the remaining 52 is female. And if you look there, you will see details of where they are coming from in Burundi and DRC. And then we also have like the age and gender details. Next slide. So basically in Nyarugusu, we are providing comprehensive primary healthcare services, and you see the details that include the reproductive health program, both BMOC and CMOC services. We also have HIV care and treatment program along with TB, mental health and psychosocial support, and the entire package. So we do secondary and tertiary medical referral to various government hospitals or private hospitals within the region and national level. And you can see the details of the facilities. In total, we have over 10 health facilities that include health posts, health centers, and hospitals that provide different range of services to the persons of concern. So these facilities are situated within the zones where we have the Congolese, because they were there before the Burundian came. And then we also have some facilities within the Burundian zone. So it's kind of like distributed equally among the both population. Next slide, please, Megan. So in Nyarugusu camp, we do have a HIV program, and you will see like the data on the HIV testing that was conducted. This is mainly voluntary counseling and testing, and provider-initiated counseling and testing at the various OPD or IPDs. This is excluding the PMTCT data, of course, and you will see there that over the course of 2017 to June 2020, the total male that was tested and the number positive, and also the total female tested and the number positive. So basically 1.7% of the total female tested were positive. And as of June, when we submitted this abstract, we had 1.5% of total male positive, and then 2.2 female positive. And for people living with HIV, we have the total of 724 as of June, but currently, of course, there are 501 PL HIV as of June 2020. This is because in Nyarugusu camp, we are doing like a resettlement program, and we also have a repatriation program as part of the durable solutions for refugees within the camp. So this is the data for HIV. When we met in our sexual and reproductive health sub-working group, we realized that the partner testing for Nyarugusu camp specifically was very, very low. The mothers or the pregnant women were not necessarily bringing their partners for testing to the facilities when requested. So as a sub-working group, we decided to have some interventions or strategies in place on how we can improve that. And this brings me to the next slide, where we'll talk about the interventions that we had in place. So basically, some of the things we look at, one was how we can actually get their involvement. because initially it was just telling the pregnant women that, okay, can you invite your partner to come to the facility for testing? And we noticed that that verbal invitation wasn't really working well and the turnout wasn't good. So we decided to have like a form of invitation that we would give to the pregnant woman at the ANC clinic to take home to her partner to come for the next ANC visit. So that is one thing we introduce in the 3 health centers and the hospital that we have reproductive health services. Another thing we also look at, and this was all developed based on focus group discussions that we also had with people in the community, with community leaders on how we can really involve partners in going to the clinic along with their pregnant women. One of the suggestions we got from the community was to kind of like have a session that would target male partner in the different households. And this session was led by the community health workers who were trained on how to conduct this session and encourage male partners to come to the facility for testing along with their pregnant women. So basically at the household level, they had a lot of discussion on the importance of partner testing and why it should be prioritized within the camp. So another intervention we also discussed and we also implemented was the engagement of the community leaders in developing strategies to enhance the community program. So basically we involved them to the extent that we even had community leaders participating sometimes in the household level sessions that we were having. And of course, at the end of the day, we also did some competency-based training to the facility staff on how to actually do the couples counseling, as well as for the community health workers on how to deliver the message appropriately within the community. So basically, if you look at the interventions, we mainly targeted the community level, the household level, to be able to improve our partner testing within Nyarugusu camp. So when we implemented this intervention, the result we got, next slide, please. The result we got, if you see here, is like the percentage of partner testing that we had in 2017 as compared to all the way coming to 2019 and 2020. So firstly, let's start with the pregnant women, the percentage of pregnant women attending ANC for the first time that were tested. That was also kind of low from 2017. We had 73% of them opting to be tested for HIV during ANC visit. But if you look over the course of time, we kind of like improve on that. We started from 73% and now we are all the way up to 95% because this is provider initiated counseling and testing. It's not mandatory, so they have the option to also opt out of testing. Coming to the partner testing in 2017, it was very low. This was because of so many beliefs, so many customs within the community. But with our interventions that are presented on the previous slide, we managed to improve this from 35% to 75% in 2018, and then it went up to 83% in 2019, and as of June 2020 is at 81%, which is kind of somehow linked to some of the issues we are having with the current pandemic. So this is what we saw when we introduced, when we implemented the interventions, especially at the community level, and we still have these interventions ongoing. And in fact, we have some of the partners that participated in this before now volunteering to go and have sessions at the household level. Next slide, please. Now, coming to the next slide, if you look there, you will see the total partners that we tested during the same period of 2017 to 2020, and then the total number that we actually enroll into the care and treatment program and put them on ART, because getting the result was one thing, but again, the enrollment was another. But we see that we out of the 48 that tested positive, 46 of them enroll on care and treatment, which is a good thing for us. And this is actually continuing. We see that almost 100% of those tested positives as of now, they are enrolled into the program. 0.3% prevalence rate we observe among the pregnant women, and among the partner tested, it was around 0.2%. If you look at the duration for referral and testing range, it was between 1 to 5 days, where we would give the woman the invitation to invite her husband, and then when they actually come to the facility, it was between 1 to 5 days. Coming to the next slide. The main challenges we have in our program implementation is that the HIV program is integrated into the national program. So we do receive the supply of test kits and drugs from the national level through the district health teams. So we observe that we have a lot of challenges with the test kits. They are not timely available, especially when we mobilize the male partners to come, they are waiting, and then we have issue of sometimes stock out. This is a big challenge that is originating all the way from the district level where we are receiving our supplies from. So to address this, what we do is for UNHCR procurement, we kind of like have some buffer stock that we do procure to have on standby just in case we run out. And we are also engaging the district health team to see how we can improve the supply chain. Condom is another big challenge, and this is something that is nationwide. Sometimes even this year, like the entire country was out of condom. This is something that UNFPA is working on addressing with the national program. This is linked to procurement regulations and some myth and belief also in Tanzania about the use of condom and what have you. CPT, the co-traumatized or preventive therapy, we do not receive at all from the government, even though there is this integration. And this is because they usually don't have enough supply. So UNHCR, we have to also supplement this. One thing we realized when WFP stopped the supplementary feeding program also for those living with HIV is that most of them stopped taking their medication. If you look at the food basket, currently is around 83%. So the supplementary feeding program was intended to supplement what they are receiving in the general food basket. So when the supplementary feeding program was stopped, we noticed a reduction in adherence to the program. With this, we introduced complementary feeding, which need like additional resources to kind of like continue. And we are not certain how we will continue with this next year with the funding challenges. Another main challenge we have is on customs and belief, of course, that is hindering the program. And this is especially with the adolescent sex education. We are having a lot of barriers within the community. So in conclusion, on the next slide, the strategy and interventions that we use, including the targeted section at the household level, engagement of the community leaders and training, kind of like help us increase the partner testing and follow up in the camps. And this approach we are currently adapting in the other 2 camps, and we are actually seeing improvement in the partner testing also, and also effective couple counseling and mobilization of the community health workers in delivery of the HIV messages at the household level also help us increase at this. So this is the key points from the summary. Thank you. Over to you.
Thank you very much, Miata. Another really important program and very challenging to get partners to be tested and notified and tested to see if they have infection. And I see you've had success there, increasing the rates up to over 80% for your partner testing, which is excellent. It's been very challenging, as you mentioned, this year with the COVID-19 and getting supplies also. So now we move to our last presentation, and then we'll open it up afterwards for discussion. Our last speaker is Carmen Logis. Carmen is from the University of Toronto. She works in the Faculty of Social Work as an associate professor there, and is also a chair of the Global Health Equity and Social Justice with Marginalized Populations. She's worked for many years with displaced and refugee persons in Haiti and the last 2 years in Uganda, working on SRH projects and a focus on HIV prevention and testing. So Carmen is going to talk about exploring associations between adolescent sexual and reproductive health, stigma, and HIV testing awareness and uptake among urban refugee and displaced youth in Kampala, Uganda. Carmen, please.
Thank you so much for having me here today. I want to start off by acknowledging some team members who were involved. Dr. Moses Okumu, Simon Muima from the Ministry of Health, Dr. Peter Chambade from Malago Hospital, Robert Hekiza from Young African Refugees for Integral Development, Peter Kabathi from Chamorro Vijana, and Claire Kapenda from Interaid Uganda. Next slide, please. So I'm just going to be going over 3 main elements today. One is the context, one is discussing our findings about HIV testing, and the third is implications. Next slide. Great. So the context for this study is working in Kampala in Uganda. So yeah, you can go to the next slide. Thanks. And 40% of the world's forcibly displaced people are under 18 years old. And young people in humanitarian crises may experience vulnerability to sexual health challenges, including HIV and STIs, for multiple reasons, including histories of previous and current sexual and gender-based violence, poverty, and constrained access to sexual health services due to factors including stigma. And we know that most people who are forcibly displaced live in contexts with overburdened health systems. And in Kampala, most of the refugees are living in slums or informal settlements that have shared social and environmental stressors. Next slide. And so there's also a global trend of refugee urbanization, with more than half of forcibly displaced people in the world living in urban settings. So in general, in informal settlements, there's not that much information and some knowledge gaps regarding stigma and HIV testing preferences and practices. And then when we look at refugees and especially refugee youth, most of the research has been conducted in settlements. So there's also very little known about urban refugee adolescents and youth when it comes to their sexual health needs and preferences. And so urban refugee youth are at the nexus of these knowledge gaps in slum health and in refugee health. Next slide, please. So there's also little information on multiple forms of stigma and how they are associated with HIV outcomes, and specifically HIV testing outcomes with urban refugee youth. For instance, we know that HIV stigma is a widely reported barrier to HIV testing across the world, but it also intersects with other forms of stigma, such as adolescent sexual and reproductive health stigma, which is values and judgment around youth when they're accessing sexual and reproductive health services and the ways that they are experiencing stereotypes and judgment for being sexually active or found out to be sexually active. Next slide, please. So this was a community-based study we did in collaboration with the Uganda Ministry of Health, YERID, Young African Refugees for Integral Development, Interaid Uganda, among many others. We first did a cross-sectional survey, which has now actually informed an HIV self-testing trial that we are just starting. Well, it's been a little delayed with COVID, with urban refugee adolescents and youth, so age 16 to 24, living in informal settlements. So for this talk, I'm mainly going to cover gender differences in HIV services awareness and testing, the adolescent sexual and reproductive health, so I'm going to call it SRH, stigma scale, and then associations between stigma, HIV-related, and adolescent SRH-related, and HIV services awareness and testing uptake with this group of urban refugee youth in Kampala. Next slide, please. You can go to the next one too. Thank you. And you can go to the next slide. So as I mentioned, this is a community-based study. We conducted peer-driven recruitment. We trained and hired young refugees in the settlements aged 18 to 24 as peer researchers who recruited all the participants from their networks. And we invited other participants to recruit their networks as well. So our main outcomes were awareness of HIV services. Are you aware of where to get an HIV test nearby where you live? And lifetime HIV testing. And our key key exposure variables were adolescent sexual and reproductive health stigma and HIV stigma. And so the scale that we used to measure adolescent sexual and reproductive health stigma was developed in Ghana for young people. And it had 3 dimensions or manifestations of stigma, including internalized stigma, so one's acceptance of negative beliefs about a practice or identity you're associated with, enacted stigma, which are acts of mistreatment and discrimination, and lay attitudes, which refer to the negative values and norms in society that one is aware of. Next slide, please. And so we did descriptive analyses, exploratory and confirmatory factor analyses of the stigma scale, and then multivariable logistic regression analyses. Next slide, please. Great. So this is one of our key findings. When we did the factor analysis, we found that the 3-factor structure in the original scale, which I just mentioned, internalized and enacted lay attitudes, did not hold in our analysis. Instead, we had a 2-factor structure. And what we found was each one of those factors had internalized, enacted, and lay attitudes dimensions in it. So this required an alternative conceptualization of stigma. So I've been working, this is with the US NIH on a lot of stigma research. And this is one of the products that we actually created, which was the Health Stigma Discrimination Framework. So all I want to point out about this, it's open access, it's in BMC Medicine, is that we conceptualized actually the root of stigma as being drivers and facilitators. So drivers of stigma include social judgment, blame, stereotypes, and prejudice, and facilitators of stigma include social and gender norms, for example. And those are marked onto particular health conditions such as HIV, as well as social identities, including gender, refugee status. And in turn, those are experienced in various ways, such as internalized and active stigma. So next slide, please. So we reconceptualized adolescent sexual and reproductive health stigma based on our findings into 2 dimensions. The first was sexual activity and pregnancy stigma. For example, some of these items were people behave differently towards a young person whom they know has had sex. Becoming pregnant and having a baby as a young person would cause people to behave differently around me. And those are just a couple, there's 14 items. And the second dimension was modern family planning and abortion stigma. People behave differently towards a young person who's had an abortion. Or the second question there is towards someone they've known has used modern family planning methods. Next slide, please. And so in our bivariate analysis, we found that girls were less likely to have completed secondary school than boys. Boys were more likely to be aware of HIV testing services. There was no gender difference in lifetime testing uptake. Overall, 2/3 of participants were aware of HIV testing services, but only 56% had ever tested. There was no gender differences in adolescent SRH stigma, but girls had higher HIV stigma. Next slide, please. And so in multivariable analysis, I just want to highlight the key findings. Sexual activity and pregnancy stigma and modern family planning and abortion stigma were linked with lower awareness of HIV testing services for urban refugee adolescent girls and young women. And modern family planning and abortion stigma was associated with lower odds of ever having had an HIV test. And this is also for adolescent girls and young women. Next slide, please. The differences with boys were quite profound. No factors were identified in this analysis that were associated with awareness of HIV testing services, and only increased age was associated with higher odds of ever having had an HIV test. Next slide, please. So, what are the implications of these findings? First, the testing prevalence of 56% among this sample of adolescent and young refugees living in Kampala is much shorter, or falls far short of the UNAIDS 90-90-90 goals, which have been revised to 95-95-95. While 2/3 knew where to access testing in their community, only 56% had tested. And of those who had ever tested, 1/3 had their test more than a year ago. Second, boys were more likely to know where to access testing, but there was no difference in testing uptake. This reinforces that testing awareness is necessary but not sufficient. Awareness does not equal uptake. Third, it was adolescent sexual and reproductive health stigma, so the negative values and community norms around adolescents who are sexually active in accessing SRH services that were associated with lower testing awareness and uptake with girls, not HIV stigma. I'm not saying HIV stigma is not still a significant factor, but in our analysis, we found that it was adolescent SRH stigma that was the significant predictor. So this is a key area that's also very underlooked when we're looking at increasing access to the HIV prevention cascade. And this is very gendered, as we did not find a statistically significant difference in the level of adolescent SRH stigma between the boys and the girls in our sample, but we did find a difference in the impact. So only adolescent SRH stigma was associated with lower HIV testing outcomes with the girls and not the boys. And fourth, how we conceptualize stigma matters and varies across context. So our study found that stigma targeting sexual activity and pregnancy and stigma targeting modern family planning and abortion were unique subscales to the adolescent SRH stigma scale. And this aligns with the drivers and facilitators in that health stigma and discrimination framework that I shared with you earlier. Next slide, please. So I just want to thank all of the study team, all of the participants, the funders. You can find more about this analyses, and if you're interested in our team's other analyses, I'm happy to share those with you. This was part of a special issue on stigma in Sexual and Reproductive Health Matters Journal. And thank you again.
Thank you very much, Carmen, for that deep dive into the impact of stigma. And we see again that it does impact the uptake of HIV services and knowledge of HIV services, but really fascinating to differentiate the different types of stigma in a very comprehensive analysis. Quite interesting and unexpected, perhaps, to find out what are the real drivers of stigma within a community. So we've reached the end of our presentations. I want to thank all of the presenters, and it's great you've all kept very well to time, so we've left time for discussion. I see that we've had just a couple of questions in the chat box so far. If people do want to come in, I suggest you either type your question in, or you can raise your hand and make a verbal intervention as well. There was an early question to Sandra about whether there is also STI testing. Sandra, did you feel you've answered that STI testing as well as HIV testing. Do you want to add anything to that?
Thank you very much, Tim. We have a wider range of tests available, and the type of test is really based on examination and individual needs of the individual patient. So it is feasible if we feel a wider range of interventions would be needed, then we have also a referral system connected to it. Thank you very much for the question, and then.
Great. Now there's another question. It's named utilizator. Do you want to make a verbal intervention? Please unmute your mic and come in if you do. It's a question to all the presenters really about how are we going to reposition HIV within humanitarian context. And this relates very much to, I think, to what Katrine mentioned earlier with the new UNAIDS strategy being developed. We need to think about the best positioning of HIV in humanitarian settings. How can we really focus on HIV in the best way? So I'll open it up to all the presenters to think about that and respond to that. But also thinking the second half of the question, we have very vulnerable people. How are we going to develop priority actions, and especially when these situations of crises are often with long-term conflict or those post-conflict peace building efforts. Does anybody from the panel wish to come in to talk about this positioning of HIV, the ideal positioning of HIV? Perhaps could I call on Carmen? I know we know that stigma is a really challenging issue that does prevent uptake. What are the particular aspects of stigma in humanitarian settings, do you think? Is it any different in more everyday settings?
Well, what we found, it's interesting you're asking me this question because we just finished a qualitative analysis. So this survey really inspired us to do more qualitative work and then to inform another study. And we just put together a qualitative paper on the experiences of stigma among young refugees. And I think there are a couple of dimensions of stigma that young urban refugees experience that are different than other youth in Kampala. One of them is stigma they perceive that they experience in healthcare settings because they're a refugee. So they experience attitudes and stereotypes towards refugees. Another element that is not necessarily stigma, but that creates some barriers is the language challenges. And so a lot of times, for example, they're allowed to access all the HIV testing services, but because of language barriers, we've been told that sometimes they don't know if they're being mistreated or not. They're not sure exactly what's going on. So there is another level of barriers that they experience where they fear that they're being stigmatized for being a refugee, and then they're not really understanding. And then the refugee sex workers have talked about particular young refugee sex workers, because we also work with Ogera, which is a refugee sex worker agency in Kampala. They say that they experience a double stigma for being a refugee and being a sex worker. And this legal precarity makes them nervous about accessing testing services. So there's an intersectional approach sort of looks at the ways that the young people we work with, their multiple identities kind of intersect to create sometimes barriers to accessing HIV testing, for example.
Right. So the double stigma, the perceived stigma, is very much heightened in the refugee setting, and something we should bear in mind when we try to formulate our responses, how to try to address that. Is there anybody else from the panel who wants to tackle this question on positioning of HIV in humanitarian contexts?
Yeah, perhaps
If
I could
not,
just add
yes,
to
Tessa?
what Carmen mentioned. Yes, thank you, Tim. I think just to build up on what Carmen just mentioned, I think a key for us is really this targeted intervention. I think every context is different, every population is different, and I think we have to very much keep in mind that a good needs assessment cannot be overestimated. And I think especially if we talk about vulnerable groups that are hidden, whether it's sex workers, whether it's transgender populations, it does take really the extra effort and the extra mile to identify them to start with and to really have targeted assessment. I think especially in the onset of humanitarian crisis, those are very easily overlooked with the enormous demands that are usually placed on all the humanitarian partners. So perhaps this is something that could be taken up in the new UNAIDS strategy. And likewise, I think the needs of adolescents, Carmen also mentioned this. I think, again, it depends very much on the context. For example, the context we are in here in Bangladesh is a very conservative society where adolescents even feel more discouraged to seek health services, where health services for reproductive health are usually perceived as only being needed for those that are married, and while we all know that there are changing population dynamics. And perhaps one of the things to look into further in the future is that the current MISP package is quite limited when it comes to HIV in the early phases of interventions. So that might also be worth to revisit perhaps then as part of a larger strategy to see, are there any areas that can be expanded from an early onset further on? Thank you very much.
Thank you, Sandra. Yes, the need for very careful needs assessments and to contextualize the responses, to look at the different cultural and geographic situation, and then to tailor responses for the different populations. The needs of people selling sex are very different to perhaps other young people or women and men, very, very varied. So tailoring is very important. Certainly come back to that question. I think that's an overarching question that please, panel members, feel free to comment on later. But we have a question also from Twabazi Jeddah. Do you want to unmute yourself, Twabazi, and come in? Go ahead, please go ahead. I can't hear you at the moment. Are you there? No, we're having trouble hearing you, Twabazi. Perhaps are you able to type your question in to the chat box? We have another. Oh, here you are. Yes. Please go ahead. We can hear you now.
Settlement. I'm very glad to be on this platform, as Madam Tessa had introduced me. Yeah, I want to comment and add something on what Tessa had presented. Most like on the challenges affecting like PMTCT services, mostly the emergency. You find that at the emergency point, as these refugees try to leave their home countries, you find they tend to think maybe the war might end tomorrow or the following day, and maybe the way. So by the time they arrive at the settlement site, you find most of the babies have been born from the bush. And that's why you find that most of the first PCR percentage coverage was very low. Most of our in-VEP refugee settlement, where you find that the coverage of first PCR, it was affected because of the late arrival of the mothers would be traveling from the bush up the border points. Then also I also comment and request that maybe we can get the action point on how can we improve on the tracking of the cross-border mothers or PMTCT clients who do move from settlement to settlement, because it has really become an issue where you find that the treaty presentation on APN. APN, it is really very good, and here in Uganda it is also working very well. I can see it is contributing almost index client positivity coming to 40%. Then maybe I also inquire to or challenge her to share with us more on how are they dealing with the anxiety faced by clients who at the time of interview, because exhaust, and it creates this confidentiality with you promise this patient that there will be confidentiality, but still you find it anxious, which has also affected on the outcome of APN. Then also feedback, where you find that instead in a certain location, let's say they are among the urban refugees, but you find that when you consult, when you try to call and follow up, the client maybe can pick you, then you link to the nearby health facility. But at the end, the feedback sometimes not given back, and which is also affecting the percentage of APN. And you find partners have been enlisted and linked to the testing point, but sometimes you are the facility which has offered APN, you don't get the feedback in time. Thank you very much.
Yeah, thank you, Tuebazi. So we had some comments there on the PMTCT presentation for Tessa. Tessa, is there anything you want to add from Tuebazi's comments?
Yeah, I think, Jada, thank you for your input. Me and Jada actually worked on the study together. But I think I want to add onto the point of the cross-border movement. I don't know specifics on other settlements or other areas, but I do know within Uganda and South Sudan, there's quite a big cross-border movement, even among established refugees in the settlements, which from public health perspective makes it really hard to follow up, as the cross-border linkages don't exist, even though the inter-settlement linkages exist. The cross-border linkages do not exist yet. So I would feel that future programming could also focus with overarching partners that function on both sides of the borders, that they could help each other out in following up on clients or even linking clients to other facilities on the other side of the border, without the limitations of having to help a person on the other side. I think also to add on Sandra, where she made a really good point, is that the stigma among the community, but I think additionally there's sometimes also stigma among the health workers themselves, where capacity building would definitely work to see how we can help this group, but also adolescents' sexual health depends on the group and the amount of, what kind of is the cultural perception about sexual behavior. To see how we could tailor this more towards these groups without them having to perceive stigma at the facility themselves.
Thank you, Tessa. I had a question. How much are you looking at a comprehensive approach to PMTCT and trying to get prongs 1 and 2 going, the education of adolescent girls, and then prong 2, the contraception and family planning for women identified as living with HIV? Is that part of the program?
Thank you, Tim. So part of the program definitely is for those women that are identified with HIV, but are not yet pregnant, together with the HIV counselors. They will look into, can I plan my pregnancy? Can I see if the viral loads are low before I start my pregnancy? But of course, it's also within the limitations of a conservative society, especially in Uganda, sexual education for minors is very challenging to give. So also the HIV counselors have to work within the limitations of the current law and guidelines of the local context. But they do try to work with those women that are not yet pregnant to see how can we plan a pregnancy and how can we reduce the chance of vertical transmission from mother to child.
Excellent, great. And then Miata, there was some comments from Twabazi about, I think, the cultural issues. How are you really overcoming some of these cultural barriers that are bringing men in? You're having some success and have got the testing rate up, but there must be some real challenges to, it's a very difficult area to do partner notification and testing. How are you overcoming the barriers?
Thank you. We are overcoming these barriers through the community structures, because while it is true that we have this custom and belief, we also have key people within the community structure that the population look up to. This could be religious leaders, it could be community leaders or people that they believe in. So if you look at the interventions we presented, we also targeted some of these groups, like the religious leaders within the different zones in the camp. We had sessions with them where they also supported us in some of these awareness or education within the churches or mosques. We also look at key decision makers that may necessarily not be like a community leader, but we have some people that they look up to, and we manage to identify these people through the community health workers who are also like incentive workers within the community. So we involve them in the community interventions and the community awareness to help us to pass on these messages to all males in the community, all males within the community. So that is what we really focus on, to be able to improve this testing with emphasis on the outcome of their decision. What will be the outcome of their decision, specifically linking it to the exposed infant from their side. So those are things that we focus on their involvement, key decision makers within the community.
Excellent, to try to reduce the stigma again of coming forward and accepting an HIV test and changing those cultural attitudes through community leadership. Was there anything else you wanted to add at this point about your experiences?
Hello, can you please repeat?
Yeah, was there anything else you wanted to add following the questions?
No, not necessarily. The statement I wanted to make, though, is this is a continuous process. It's not something that can be done and achieved within a short period of time. And even with achievement, you have to continue these interventions, because you will always have a situation where someone will just come and then try to like change everything in the sense that they will come up with information or some myth within the community that will kind of like set you back. But we continue to be persistent, like very following up closely and continuously having these interventions in the community and not stopping, because the minute you stop, it kind of like start reducing again their intention. So we continuously like try to emphasize on this at the household level and the community level. This is what I wanted to add.
Yeah, thank you. You really have to maintain the momentum for sustainability. Yes, absolutely. Thank you. So we have another question from Ankur Rakesh, who's really thinking about the surveillance of STIs and HIV, and whether there's a need to increase the community-based surveillance, building this into UNHCR's broader surveillance in refugee settings, the surveillance of nutrition, other diseases and outbreaks. Is anybody from the panel wish to make a comment on any surveillance gaps on HIV and other STIs?
Maybe I can just add something to this. This is Katrine. The way I understand the question, it refers to the house surveys, so it's more the community-based surveys. Is that correct, Anu? Ankur, is that correct? You're referring to the house survey?
Yes, Ankur mentioned the community-based surveillance.
Yeah. So, because I mean, for general feedback to everybody, the health information system in UNHCR obviously tracks information on STIs and HIV. I would be happy to have other team members from UNHCR in Geneva or anywhere intervene, but it's clear that in the house survey, at the present stage there is no specific questions on this, and it is very likely due to the fact that they are highly sensitive and there is confidentiality issues involved regarding HIV, whether or not the question could be included to see, are people aware of the fact that testing is available or something like that, is something that could be discussed. I don't know if somebody else from the team wants to intervene on that one.
Catherine, do you want me to jump in? Vincent?
Yes, please, Vincent, do.
Yeah, thanks, Anku, for your question. This Vincent, UNHCR, used to be HIS before. Yeah, your question is valid. Our community-based surveillance is mainly geared towards disease, morbidity and mortality surveillance. However, if you look at the whole surveillance system for UNHCR, HIV is one of the components of the surveillance system. Additionally, within refugee camps, there are well-established community health programs that report on HIV and STIs. However, from the UNHCR side, we really insist on integration of such programs into national health systems when in protracted situations, or during emergency, just report on a bare minimum that would allow us provide life-saving interventions. So if you look at what's already existing in the camp, you'll find a lot of programmatic elements going on in the field in terms that support defaulter tracing, that support community level testing, and also even report on other things like risk communication on HIV and STI. STI reporting is integrated within disease surveillance, both at community and facility level, but there is also an opportunity to report on STIs using syndromic both at facility and the community level. But I agree with the Anko that this is an area that needs a lot of improvement, and UNHCR is looking at expanding more on the community-based surveillance aspect of their health information system. Thanks.
Thank you, Vincent. I think this relates back to the comment on the need for good needs assessments and really finding out the cultural context and what are the specific needs of different groups. So that really sort of assessment phase is crucial for then shaping the interventions for the different groups. Something to think about in how to get greater knowledge, attitudes, and practices of people. Okay, we have another question for Carmen. The very interesting presentation on the SRH stigma in girls. This is from Ricky Jansen. And how does this relate to the overall gender differences in provision of services for HIV, other STIs, and SRH services?
I think that's a really great question because, as I mentioned, we didn't find the actual scores differed between the boys and the girls, but we found the impacts did. So I think that has to do with the double standards that adolescent girls and young women experience when they're sexually active. So they're often blamed, shamed, devalued, whereas the same situation doesn't happen necessarily for boys. And a lot of the responsibility for sexual and reproductive health care falls on girls. And what we specifically measured was around modern family planning, so oral contraceptives, abortion, for example. Pregnancies are usually more impacting, the person who's pregnant who's, than necessarily the partner, especially for young people. So I do think that when it comes to age, in our qualitative data reflects this as well from the same population, that when they go in to get, say, an HIV test, or they go in to get contraception, instead of being congratulated and celebrated for taking care of their own sexual and reproductive health, they're actually shamed and said, "What are you doing that you need this? You must be a bad person, a bad girl, you're spoiled now." So they're getting from the healthcare provider, as well as from the outside people who see them, the fear of going for a test was so profound with the adolescents we're working with who are urban refugees. Just the fear of going and having somebody associate them with that because of the judgment that they're sexually active. So I feel like there needs to be much more attention to that dimension of adolescent sexual and reproductive health stigma, about how adolescents are not celebrated and congratulated for taking care of their sexual and reproductive health. So because they're not, and they're actually having a negative repercussions of taking care of their sexual and reproductive health, they're not going to do that anymore. We don't normally, it's a deterrent. We don't normally do something where we experience a lot of stigma and judgment and blame. And so I do think, from this scale was developed in Ghana to look at the association with contraception uptake. We adapted it for HIV testing uptake. So I feel like understanding the way that we shame and judge sexually active adolescents across the spectrum of sexual and reproductive health, from contraception to HIV testing uptake, is important.
Thanks, Carmen. Sorry, Tim, if I could just follow up that question a bit. It's Ricky speaking. Exactly kind of what I was trying to get at. Thanks so much for that answer, Carmen. And I was also wondering then if maybe you or some of the other presenters, if we have time, could reflect then on not only from the position of girls, but also what kinds of services we're offering for men and boys. I did my field work in Cape Town, and something, that I found very striking was women were continuously being brought in because of pregnancy or family planning. And because of that, often had much higher rates of practitioner-initiated care and testing around HIV than men did. So I just wondered, in the refugee or settlement context, with this new current provision of reproductive and sexual health services for men. Thank you.
Thank you, Ricky. Does anybody want to add?
Thank you, Tim. I think I want to add on, Ricky, what you rightfully mentioned is that most of our programs do target women, or women at least for sure are tested throughout their life several times during their pregnancy. Every antenatal care visit, almost you get an HIV test, or at least 3 times throughout your pregnancy, which means we capture the women to test them for HIV. And then when they become positive, they're often also blamed for being HIV positive, while their partner might be the one giving it to them. So I do think sometimes with our programs, even though they're rightfully, testing women for HIV throughout their pregnancy because of a prevention to mother-child kind of perspective, we also might enforce the stigma on these women for them being the first one being identified as HIV positive. This is why I also think that Miata's project was so intriguing, because if you test them both at the same time, this might be one of the ways to at least get the blame out of the women a little bit less, because we do see domestic violence after women are identified as HIV positive during their pregnancy. So it would be interesting to see how we could target programs maybe more towards men, so that we get away the stigma of the women. And as we said to Carmen, like, celebrate that women seek health, or people seek health for their sexual reproductive health needs, rather than blaming them from an outcome that comes out.
Yeah, exactly. We continue to see the stigma and the negative attitudes. We have to change those attitudes, and so that it's a health issue, not something about blame and trying to pass judgment. And we would hope that healthcare services would be a safe haven. It's hard enough for people in these very difficult contexts, and they should be able to at least come into a clinic and be received very respectfully respectfully and without judgment, but that's often not the case. So the healthcare worker attitudes are critical, aren't they? You've touched there on violence, and there was another question for Sandra about the violence to the sex workers, either from clients or authorities, and what sort of psychosocial support there are for people who are selling sex in the Rohingya population.
Yeah, thank you for this question. A great question, really. We have in the early assessment when we started the project, that's one of the areas where we felt it was not enough addressed in the existing centers. So we have dedicated psychologists working in the facilities and the drop-in centers who provide individual counseling to the women, but we also have small group sessions for psychosocial support among the women. We similarly, it was a bit more difficult in the camps, since leaving the camps, coming to the drop-in center is always a little bit more difficult, especially if it's for regular sessions. So we could solve this to a certain extent now through our health partners, who also have psychologists and MHGAP trained staff in their facilities. Where we still face problems is if we have women who are highly traumatized, and I have seen one or two of them that really went through very, very difficult times in combination with having to flee their home. And I think this is where we all feel still the referral system isn't strong enough. There's one psychiatrist in Cox's Bazar for 3 million people, and there's very little really highly specialized support. So we look with different partners then to see on how we can support also the women who have needs that are beyond the centers. But I think for most of them, we have at least a support system in the centers. Thank you very much. Over to you.
Thank you, Sandra. I think that I don't see any more questions in the chat. Is there anybody else who wishes to intervene, come in with their hand up? Are there any more closing remarks from the panel that you want to make? Perhaps we could go through. Sandra, is there anything else you wish to add, particularly about this looking forward? How do we strengthen our focus on HIV in humanitarian settings for the UNAIDS strategy?
Thank you. We really try to focus here in the context on enhancing access to service. I think stigma is a topic that came a lot, and I think this is really where perhaps the new strategy would need to have an even stronger focus than it already is on new innovative ways. There are new methods of communication, new ways of engaging with communities that we all learn every day to see how we can address this even better, that people feel free to come forward, but also how to convince others then in the community to accept people regardless of their HIV status or also regardless of their sexual orientation, which is still very, very difficult in many circumstances. So that would be certainly an area where we look for more guidance in the new strategy. Thank you. Over to you. And thank you again for all the great questions and the opportunity to be here today. Over.
Yeah, thank you, Sandra. The multi-layers of stigma coming through very clearly and then really highlighted in the humanitarian setting. Tessa, were there any other remarks you want to make?
No, I think I want to add on, Sandra, that I think HIV is not just a healthcare issue. It's one with a lot of protection concerns, and it needs a multi-partner and human rights approach for us to really tackle not just the health aspect, but I think also the protection needs of this vulnerable population, which I think came across in all the 4 presentations, which I found very intriguing to see.
Thank you. Yes, it's really, we need to maintain this multi-sectoral response and not just view it as a health issue. It's touched every aspect of our lives, hasn't it? So it's finding the nuances of how to have different multi-sectoral approaches within the humanitarian setting and within the MISP to maintain HIV is as another as an important aspect of the MISP and initial responses. Miata, do you have any further comments?
Perhaps I would like to comment on, like, as I said, the continuous community engagement. I think this will also help us to tackle this issue of stigma. And for the adolescents specifically, I think we also need to look at the non-traditional way of providing HIV services also. For example, in the refugee camps in Tanzania, we do have HIV counseling and testing and family planning or SRH services at the different youth centers where these youths go to like play games or discuss and have different activities. So that is one thing that is also helping us. But again, the gap there is those adolescents that remain at home and are not actively participating in those activities at the different youth centers. I think we need to continuously come up with strategies to see how we can tackle and address those issues. That is the comment I have. Thank you. Over.
Yeah, thank you very much, Miata. And Carmen, any concluding remarks?
Yes, I think I have two comments. One of them is there is a large body of stigma science that I feel we could leverage in thinking through how to reduce stigma in humanitarian contexts, really thinking about the social ecological context from working on people's own self-esteem and internalized stigma to families and intimate partners to communities to health centers to religious centers. So really looking at a social ecological and an intersectional approach so that we really don't leave out sex working people, LGBTQ people, and also things that we might overlook. Right now I'm working in with collaborators in BDBD settlement around reducing sexual violence stigma. So the stigma about having experienced sexual violence. So how do we measure that and how do we actually move the needle on that? And the second thing I just wanted to briefly say was I agree with the last speaker who mentioned innovative strategies for HIV testing. We are implementing an HIV self-testing trial with urban refugees right now. COVID has kind of gotten in the way, but thinking about HIV self-testing, but also really carefully considering the needs of the population. For in our qualitative work, they very clearly stated that partner HIV self-testing might increase violence. So we are not implementing partner testing for this group of adolescent and young refugees. So really thinking about how do we translate some of the innovations, but in ways that are super community-based and cognizant of the realities and the needs of the population.
Thank you very much. Yes, well, we'll continue to value your inputs and insights on reducing stigma and really understanding the multiple layers of stigma and how it affects different young men and young women as well, and how do we really tease those out and change the community attitudes, hopefully to make people more accepting. From UNFPA's side, I think, to me, the challenge for UNAIDS is really moving from a disease focus to a person focused now. And whilst programs really are person focused, I think UNAIDS has historically come from a very vertical approach, focusing an exceptional response on HIV, and that was rightly so, and it's had an amazing impact and really reduced HIV transmission. But now we're really needing to see an integrated approach and move to really meeting people's needs, differentiating the integrated services for sex workers, for young people, for LGBTI persons, and for pregnant women and their partners, so that within the MISP we really retain HIV, and I think also expanding the focus to other sexually transmitted infections and perhaps some bloodborne infections where that's appropriate. So we don't just focus on HIV and the HIV test. We think about how do the services really meet the needs of people, and we see that in PMTCT programs now looking at prevention of syphilis as well as hepatitis B. We see the adolescent programs really looking at all of the sexual and reproductive health needs of young people. The sex workers have reproductive health needs as well. It's not just an HIV test. So how do we, within the very constrained approaches of the MISP, we have to carve out a niche for HIV, but make it very much people-centered and as a part of the broader services. I want to round off now and thank all the presenters very much for their fantastic presentations, really very important issues in and showing the great diversity of programs. And it's been a pleasure to host this, and I will turn back to Katrine and Hilary for any closing remarks. Thank you.
Hilary, do you want to go first?
Sure. Thank you so much to Tim, to our four wonderful presenters. This was a fantastic 2 hours of discussion and learning. And we're so excited to have had the opportunity to have you all here today. And for those who are watching in the future, thank you for coming back to this presentation. We hope that it will help guide learning and knowledge and discussion for many years to come. On behalf of IWOG and this STIs and HIV Subworking Group, again, thank you all. We're really pleased with this outcome, and we're hoping that you'll all sign up for future webinars with us, and don't hesitate to reach out to the IWOG or to me if you have any questions. So thank you all.
Thank you, Hilary. And from the UNHCR team, thank you everybody for joining. And thank you for the presenters and the fantastic discussion. It was very insightful, and I think we go away with some important thoughts regarding the strategy ahead and the specific considerations for humanitarian contexts. In response to some of the comments that came up, I would like to reassure you we have recorded the session. We will make a link available. Please look out for on the IWAG website to see if you find a link there. If not, you can get in touch with Megan or myself or Hilary. We make sure that we can give you the link. We will also be able to give you the consolidated presentation, which combines the 4 different presentations that you have seen. Special thanks to Megan, who's works with UNHCR, with our team, and who's done all the logistics and setup and reservations. And thank you again for Tim to moderate this so great, and to the 4 presenters for their preparation, the abstracts, the updates, and their great presentation. Thank you very much, everybody. And have a good afternoon.